Renal cell carcinoma, pathophysiology, diagnosis, and treatment. Renal cell carcinoma is the predominant form of kidney cancer in adults, arising from tubular epithelial cells. Understanding its molecular mechanisms and treatment approaches is essential for improving patient outcomes. Understanding renal cell carcinoma. Renal cell carcinoma represents the most prevalent malignancy affecting the kidneys in the adult population, accounting for the vast majority of all kidney cancers diagnosed annually. This malignant process originates within the epithelial cells lining the proximal convoluted tubules, which are microscopic structures responsible for filtering blood and forming urine. The disease demonstrates a significant male predominance and typically affects individuals in their later decades of life. Understanding the biological nature of RCC is fundamental to recognizing its aggressive potential and implementing appropriate diagnostic and therapeutic strategies. Epidemiology and risk factors. The incidence of renal cell carcinoma continues to rise in developed nations, largely due to enhanced imaging capabilities that detect incidental kidney masses. The disease demonstrates a clear male predominance, with men being approximately twice as likely to develop RCC compared to women. Age represents a significant risk factor, with the median age at diagnosis occurring in patients over 60 years. Several modifiable and non-modifiable risk factors contribute to RCC development, including smoking, obesity, hypertension, and chronic kidney disease. Additionally, genetic syndromes such as von Hippel-Lindau disease, hereditary papillary renal carcinoma, and Birt-Hogg-Dubé syndrome substantially elevate the risk of developing RCC. Key points: smoking increases risk through exposure to carcinogenic compounds filtered by kidneys. Obesity and hypertension, associated with metabolic alterations and inflammation. Chronic kidney disease and dialysis, prolonged renal dysfunction increases transformation risk. Genetic syndromes, hereditary conditions cause predisposition through gene mutations. Molecular and histological classification. Renal cell carcinoma encompasses multiple distinct subtypes, each with different biological behaviors, genetic alterations, and treatment responses. The clear cell variant represents the most common form, comprising approximately 70 to 80% of all RCC cases. This subtype frequently demonstrates inactivation of the VHL gene, leading to accumulation of hypoxia-inducible factors and subsequent angiogenesis. Papillary RCC, constituting 10 to 15% of cases, often involves mutations in the MET proto-oncogene. Chromophobe RCC, accounting for 5% of RCC diagnoses, generally carries a more favorable prognosis. Other less common variants include multilocular cystic RCC, collecting duct carcinoma, and renal medullary carcinoma. Recognition of histological subtype carries prognostic significance and increasingly influences treatment selection. Clinical presentation and diagnostic approach. The clinical presentation of renal cell carcinoma varies considerably depending on disease stage and extent of spread. Early-stage disease is frequently asymptomatic and discovered incidentally on imaging performed for unrelated reasons. When symptoms do manifest, patients may experience flank pain, hematuria, or constitutional symptoms such as fever and weight loss. The classic triad of gross hematuria, flank pain, and palpable abdominal mass occurs in a minority of patients and typically indicates more advanced disease. Modern diagnostic evaluation relies primarily on cross-sectional imaging modalities, with computed tomography and magnetic resonance imaging providing excellent visualization of renal masses and assessment of metastatic disease. Key points: imaging characteristics. Enhancement patterns help differentiate benign from malignant lesions. Incidental discovery. Majority of RCC found on imaging for other indications. Laboratory findings: anemia, elevated erythrocyte sedimentation rate, hypercalcemia. Staging workup: chest imaging and bone evaluation to detect metastases. Staging and prognostic assessment. Accurate staging of renal cell carcinoma remains essential for treatment planning and prognostication. The TNM staging system incorporates tumor size, invasion into surrounding structures, lymph node involvement, and presence of distant metastases. Stage I disease includes tumors confined to the kidney without extension beyond the renal capsule, representing the most favorable category. Stage II encompasses larger tumors still limited to the kidney, while Stage III includes those with vascular invasion or regional lymph node metastases. Stage IV disease encompasses locally advanced tumors with invasion into adjacent structures or presence of distant metastases, representing the most aggressive presentation. Beyond TNM staging, numerous prognostic models have been developed incorporating clinical and pathological variables to enhance risk stratification and treatment selection. Surgical management strategies. Surgical resection remains the cornerstone of curative treatment for localized renal cell carcinoma. Nephrectomy, the removal of the affected kidney, represents the definitive treatment for most patients with clinically localized disease. Partial nephrectomy, which preserves renal parenchyma, has become increasingly favored for smaller tumors when technically feasible, as it provides equivalent oncological outcomes while preserving renal function. Radical nephrectomy involves removal of the kidney, adrenal gland, and surrounding fascia, with or without regional lymph node dissection depending on clinical circumstances. For patients with metastatic disease at presentation, cytoreductive nephrectomy may provide benefit when combined with systemic therapy, though patient selection remains critical. Key points: partial nephrectomy, preferred for tumors less than 4 cm or when feasible for larger lesions. Radical nephrectomy, standard approach for larger or more advanced tumors. Minimally invasive techniques, robotic and laparoscopic approaches reduce morbidity. Lymph node dissection, individualized based on tumor stage and location. Systemic therapy and targeted approaches. Recent decades have witnessed revolutionary advances in systemic treatment options for metastatic and advanced renal cell carcinoma. Targeted therapies directed against specific molecular pathways have substantially improved outcomes. Tyrosine kinase inhibitors targeting the vascular endothelial growth factor pathway have demonstrated efficacy in reducing tumor progression and extending survival. These agents work by disrupting angiogenesis, the process through which tumors develop new blood vessels necessary for growth. Additional targeted agents address the mammalian target of rapamycin pathway, providing alternative mechanisms of action. Combination regimens incorporating multiple targeted agents have shown improved efficacy compared to single-agent approaches, though increased toxicity must be carefully managed. Immunotherapy and contemporary treatment paradigms. Immunotherapy has emerged as a transformative treatment modality for renal cell carcinoma, fundamentally reshaping the therapeutic landscape. Checkpoint inhibitors that enhance the immune system's ability to recognize and destroy cancer cells have demonstrated remarkable clinical activity. These agents, which target programmed Death-1 and cytotoxic T lymphocyte-associated protein 4 pathways, have improved progression-free and overall survival rates across multiple clinical trials. The combination of checkpoint inhibitors with targeted anti-angiogenic agents has proven superior to either class of drug alone, establishing new treatment paradigms for both first-line and subsequent-line therapy. Ongoing research continues to identify biomarkers predictive of immunotherapy response, aiming to optimize patient selection and maximize benefit. Key points: checkpoint inhibitors, pembrolizumab, nivolumab, and atezolizumab demonstrate clinical activity. Combination regimens, immunotherapy plus targeted therapy shows superior efficacy. Biomarker development, PD-L1 expression and tumor mutational burden under investigation. Adverse event management, immune-related complications require specialized monitoring. Monitoring and follow-up strategies. Appropriate surveillance following treatment of renal cell carcinoma aims to detect recurrence and metastatic disease at the earliest opportunity while minimizing unnecessary investigations. The intensity and frequency of monitoring should be individualized based on initial stage, grade, and other prognostic factors. Early-stage disease treated with surgery typically requires imaging surveillance at defined intervals, with frequency decreasing over time as the risk of late recurrence diminishes. Patients with advanced disease or those undergoing systemic therapy require more frequent assessment to evaluate treatment response and detect progressive disease. Regular laboratory evaluation, including assessment of renal function and hemoglobin, provides additional information regarding treatment tolerance and disease status. Challenges and future directions. Despite significant therapeutic advances, renal cell carcinoma continues to present substantial clinical challenges. Treatment resistance and disease progression remain major obstacles in achieving durable responses, particularly in patients with advanced disease. The development of secondary resistance to targeted therapies necessitates the availability of multiple sequential treatment options. Ongoing research focuses on identifying molecular mechanisms underlying treatment resistance, aiming to develop predictive biomarkers and novel therapeutic targets. Precision medicine approaches attempting to tailor treatment based on individual tumor characteristics and host factors represent an important future direction. Additionally, investigation of novel combination strategies, rational sequencing of available agents, and development of entirely new drug classes targeting previously undrugged pathways offer promise for further improving outcomes. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.